Today we're going to talk about pinchy hips. So, pinchy hips, obviously, it's just a general term that I like to use. It's not a medical diagnosis, but pinchy hips basically describes maybe multiple different anatomical conditions that could lead to a sensation of pinching, often in the front of the hip. So, it could be an anatomical abnormality leading to this, it could be a labral tear as well. Um, Different reasons why, but our treatment's going to be the same. So we're just going to go through a little bit of anatomy and show you some pictures of what your hip joint looks like, how it's supposed to move, and then we will talk about strategies to continue moving with this condition and how we can actually make it better. And then on Thursday this week, we're going to go through some of those exercises together on what I recommend for this condition. So first thing about the hip is it's a ball and socket joint. So if you take a look at this picture on the left, the red part is the ball that's the head of the femur that sits in your acetabulum. Your acetabulum is just like that little socket that it sits in. So that's what it looks like. Ball and socket joint moves in all different directions. So some joints move forward and backwards, some joints move side to side. Some can do forward, backwards, side to side, and rotation. And this one does all of it. If you look at the picture on the right, a little bit of anatomy, you can see there's the pelvis. Um, that big thing to the right that has all the holes in it, that's your sacrum. So right above that is your SI joint. You may deal with some instability there as well. And then you can go down to your femur. That is just your leg bone. Femoral head is again that ball that sits in the acetabulum, which is the socket. And then the one thing I want you to really look at is the labrum. Labrum is just like this little piece of tissue that wraps around the joint to help seal it in place. Think of it kind of as like glue, suction that holds it there. A lot of people have labral tears that are not symptomatic, so if you have one, it is nothing to necessarily be concerned about. If you're dealing with a lot of hip dislocating and you have a pretty significant tear, that could be one reason that it is continuing to dislocate. The shoulder is a similar type of joint. It's ball and socket, but it's also more complicated. Um, but you have a labrum there as well, and often we find labral tears in the shoulder. This is just a closer image that you can really see that labrum, that little piece of tissue that wraps around. The white on the joint is cartilage. So that's to keep it smooth. That's like the grease, so that it can move smoothly. So as your joints wear down over time, we lose some of that cartilage, so it's a little bit more ruggedy, which might be why you get some popping and clicking. And then like the white kind of fibrous layer looks kind of like those lines in it to the left and the right of the labrum. Those are some of your ligaments that are holding that joint in place as well. All right, I think that's it for that picture. So, a couple different options. We talked about that labrum. Some of those labral tears can also contribute to that popping and clicking in your joint. That's because you can get little fraying. It's just like a tissue. You can get some fraying, and sometimes that hip sort of pops over that. Um, you may have a labral tear that's not symptomatic, and then maybe one day you do a squat that's too low and you load it up, and then it's flared up. That can happen. I would say I definitely have one undiagnosed, and occasionally it'll get flared up, and then I know what exercises to do to take the pressure off of it so that I can get back to my normal movement routine, and that's what we're going to talk about. As far as a structural standpoint, you may hear something as far as like a true hip impingement. So, a couple different types. Cam and pincer are ones that you'll hear about. So basically, whether it's due to a bone spur or just structural abnormality, the head that sits in the socket is either too big or the socket is too overgrown. Um, so it depends on if it's the socket or the head of the femur that has that extra bony surface that literally causes the bone to pinch. You also can have some combination of these two. Just because you have one of these doesn't mean it's symptomatic, but these are other reasons that you could have a true hip impingement. I treat hip impingement exactly the same as a labral tear. Um, so again, if you have one of these, even if it's structural, it doesn't mean we can't work around it. And then from a muscular standpoint, lots of muscles around this area. This picture might be a little overwhelming, but here's a bunch of muscles. So this is like your rib cage all the way down through your pelvis to your femur. So we're just putting the muscles on top of that previous picture just to show you, and this isn't even all of them. This is just like some deep muscles. So we got your psoas, we've got some of those deep core muscles. We've got muscles that attach to your knee that go all the way up to your hip, like your quads, your adductors. There's a lot involved. Just to kind of show you the complexity of muscles in this area. You have deep muscles, you have some more superficial muscles that are more on top. And so when it comes to the hip, because of all these muscles around it, one, we want to make sure that all these muscles are strong, but we also want to protect the bone underneath. And so as far as treatment, if we take this joint over, taking your hip over 90 degrees, so say maybe you can sit in like a high chair, but not a low chair due to that position, we want to prevent the bones from kind of aggravating each other. Again, whether it's structural or due to like a labral tear. So squats are a big one with this. Another reason I cue squats to a chair very often. And then that's one thing we want to pay attention to. And then the rotation as well of the joint. Here, this picture's better. To make sure we're not flaring up these symptoms. And so if you have a lot of external or a lot of internal rotation of your pelvis, we just want to come back a little bit more to the middle and not to the extremes where the bones or um, the joint and the ligaments are constantly being tensed, loaded, or stressed. So on Thursday, what we're going to do is we're going to talk about some other ways, kind of some practical ways, what we just talked about on how you can modify activity when you have this. Usually it'll be about 6 to 8 weeks of modifying and gradually loading until you should become asymptomatic. If we're a mild tear, honestly, even to moderate. There are some people that might benefit from surgery if you have a pretty severe tear, but that's going to be at the discretion of you and your doctor. Even if you choose to go surgical route and you're hypermobile, we've got to make sure you are strong going into it. And so I always advise at least 6 to 8 weeks of strengthening before even going that route. But obviously, go with what your doctor says over me because your doctor knows your individual circumstances. This is general information. All right, there's all your muscles. We're going to get these muscles strong. So that's going to mainly look like activity modification, core strength, and hip strength to take pressure off this joint. So I will see you on Thursday to kind of put this information into practice. Please comment if you learned anything or if you have any questions so that I can answer it in a future video. And I hope you learned something new today. And yeah, thanks for watching.